Okay, good morning, everybody. Thank you, Professor Sheba, for the invitation to the lecture. So I will talk about the possibility to make the diagnosis of coronary artery disease using a MRI. The main point that I would like to talk about it is why we need a cardiac MRI. The second point is to talk about the Dobutamine and adenosine stress MRI. And the third point is to talk about MRI angiography. So the question is, if we need, in addition to all of these excellent imaging modality that we have in the cardiology, in addition to all of them, cardiac MRI, we have echocardiography, 2D, 3D echocardiography, we have invasive angiography, we have SPECT, we have cardiac CT. The question is if we have, in addition to all of these excellent modalities, cardiac MRI. So the advantage of MRI is the interstudy reproducibility. If we perform, as we can see with using MRI, the interstudy reproducibility is relatively low compared with echocardiography. As we can see in this this movie, we see the excellent endocardial border delineation mainly in the apex, in the right ventricle. If we compare it with the echocardiography, it may be a little bit difficult to identify the apex or the right ventricle. So it is better to use a 3D imaging modality. Using MRI, we are able to quantify the volume in every slice. That is the reasons why cardiac MRI is the reference standard for LV and RV volume and ejection fraction. MRI is able to reduce the sample size. If we want to show any difference, a 10 milliliter difference in end-diastolic volume, we need 39 patients, 39 echocardiography exams. By MRI, we only need 10 exams. So using MRI, we can reduce the sample size, we can reduce the cost of the trials. So what is about SPECT? The problem with SPECT is the spatial resolution. If we have a relatively small subendocardial myocardial infarction, using SPECT, it may be that we cannot see this myocardial infarction. With MRI, because of the excellent image quality and the excellent spatial resolution, we can identify the myocardial infarction. That is an important point. And this may explain the results of the CE-MARC, which is a head-to-head comparison between cardiac MRI and SPECT. We see a better diagnostic performance of perfusion MRI compared with perfusion SPECT. The sensitivity of the multiparametric MRI is higher than SPECT. The authors use here perfusion defect and wall motion abnormality to identify a positive perfusion test. What's about CT? I perform a lot of CT scan, but CT have also a little bit limitation. CT is indicated in patients with intermediate pretest probability, low to intermediate pretest probability. If we include patients with relative low pretest probability, the positive predictive value of the CT may be relatively low. On the other side, if we include patients with high pretest probability, the negative predictive value can be low. And that is explain the guidelines, which the European guidelines regarding the management of patients with stable coronary artery disease. They concluded that CT is only indicated in patients with low to intermediate pretest probability. It is not indicated in patients with prior revascularization. It is not indicated as screening test. So how can we manage our patients with a suspected coronary artery disease using MRI? We can detect ischemia using Dobutamine or using adenosine stress. We can perform also MRI angiography. So I will start with the Dobutamine stress test using MRI. We use the same protocol as in echocardiography. At rest, we perform steno images in short axis and long axis. We give Dobutamine to reach the target heart rate, and at the end of the study, we perform a delayed enhancement scan. What is about the safety? We have to make a monitoring during the study. We have to measure the blood pressure and to make a respiratory control. What is about the safety of the Dobutamine stress MRI? It is have the same safety profile like the Dobutamine stress echo. I would like to show you a couple of examples of the Dobutamine stress MRI. 52 years old patients with multiple PCI to the circumflex. He came to us because of chest pain. The image quality of echocardiography was borderline. The patients performed stress test. You can see clearly the contractility of the myocardium. You can see clearly the apex. You can see clearly the right ventricle. If we give the patients low dose dobutamine, the contractility improved, as we can see it here, at 20 microgram per kilogram per minute. And at high dose, we see clearly wall motion abnormality in the lateral wall. We send the patient to the cath lab, and we can see a significant stenosis at the ostium of the first marginal branch. Another example of a patient with dobutamine stress MRI, we see here the end systolic frames, and here we see the end, the end diastolic frames, we have the end systolic frame. We see at the peak dose of dobutamine, we see wall motion abnormality at the apex. The patients have a significant lesion in the LAD. Another examples of stress MRI, dobutamine stress MRI, that is the rest imagings. The contractility improved by increasing the dose of dobutamine. At high dose dobutamine, we see wall motion abnormality, and we can see mitral regurgitation. Using the short axis, we can also see the wall motion abnormality. We can see the wall motion abnormality.
Can you please move to the coronary imaging, please?
Okay.
Would be very interested in that. Thank you.
Okay, we will go to the coronary angiography. So we have a lot of data regarding the dobutamine stress MRI, regarding the feasibility, regarding the diagnostic performance, and regarding the prognostic value. I will just go to the last issue of this session. We'll talk about coronary angiography. Well, have a relatively limited indication in the clinical use, but if we have the questions regarding coronary anomalies, it could be indicated. The challenge with MRI coronary angiography is that we have relatively small coronary artery diameters. We have motion artifacts because of the coronaries and the respiratory. We are able, using MRI, to prospectively define the rest period of the coronary artery. As we can see, at end diastole, just concentrate in this green point. The coronary artery does not move at diastole. We can measure this time, and we can plan our exams that we can measure the time of the rest period, and we can perform the acquisition exactly at the rest time of the RCA. In this way, we can compensate this problem. Regarding the respiratory motion, we are using the navigator technique. During my fellowship, we developed at the German Heart Institute an MRI sequence which can perform very well coronary angiography. We compare the diagnostic performance of a 3 Tesla MRI with CT, where the invasive angiography was the gold standard. We performed a 2-center study, and we included patients with suspected or non-coronary artery disease. I will show you the result of the study. The diagnostic performance of MRI and CT was excellent, and there was no difference between of them. I will show you an example of volume rendering using MRI, using CT, invasive angiography. These patients have a normal CT, MRI, and invasive angiography. The second example is patients with significant stenosis in the LAD, as we can see it here. With the MRI images, with the CT, we have heavily calcified lesions, and in the circumflex, we have also lesions using the MRI images and the CT. The invasive angiograms can show us the same results, significant lesions in the LAD and in the circumflex. We follow up these patients for about 48 months, and we have in this population 38 event rate, and we are able to show that cardiac CT and cardiac MRI are able to predict the events over a period of 4 years. And the difference between of them was not statistically significant. So we can conclude that's the last, that's the conclusion of all of this talk. I did not really talk about Dobutamine and adenosine stress MRI, but we have really in cardiology excellent imaging modality in which we can perform a lot of diagnostic possibilities. It is the gold standard for quantification of LV ejection fraction and volumes. The Dobutamine and adenosine diagnostic performance is excellent. We have excellent prognostic value, and MRI we can using MRI we can able to perform tissue characteristics. Thank you.
Thank you very much, Dr. Hamdan, for being precise and outstanding. Thank you very much. Perhaps Professor Rosenman for
just one sentence because we are in a short of time. First of all, I would like to thank Professor Verd for the organizing this session. I think it was a wonderful session. So I would like to thank you and all the speakers. I think on behalf of the Israel Heart Society, I think it's an honor for us to have such a session for the memory of someone that really deserves to be remembered as someone that has a significant role in the history of cardiology of Israel in Israel. So really, thank you very much. And it was a great session. And once again, an honor for the Israel Heart Society to have such a session. So thank you all very much.